So may I invite Dr. Arindam Datto to conduct the next session on nutrition in respiratory patients. I request Dr. Mitara Sengupta and Dr. Guru Prasad Bhattacharya to join in for the panel.
Okay, good evening everyone. We are running much late than the schedule, and I will try to keep it as short and as crisp as it can be. So we had already modified the presentation to suit the time, and I will try to catch up the things. Okay, so before I go forward, I would like to introduce the esteemed panelists. Okay, so Dr. Mitara Sengupta. She is a very eminent and a senior pulmonologist from Howrah and Kolkata. She is one of the oldest pulmonology consultants in Narayana as well as CMRI. Then we have Dr. Saurabh Kole, who is also a very esteemed intensivist from Kolkata. And sir, along with Madam, has been a cornerstone behind our society from the very beginning. And thank you, sir, for coming. And also our dear Guruda, Dr. Guru Prasad Bhattacharya. He is also an eminent physician from Howrah. So I think most of the issues has been covered till now, because we have done so far a generalized discussion, even in spite the topics were much related to some certain topics like cancer or recent advances or pediatrics. So, but I think all 3-4 discussions are more than enough to cover the general concept for nutrition and the critical care, and also that encompasses the general principles for a respiratory care patient. So here we go. This is our case 1. This is a very short, crisp and a very typical case. So this is Mr. AB, 65 years male, complaining of shortness of breath with MMRC grade 4. Cough and purulent expectoration. His status post PTCA. On examination, bilateral bronchi, decreased air entry bilaterally. On NIV, his ABG reveals 7.2 pH, 76 PCO2, PO2 of 46, and a BICAP of 37. His BMI is 16.3 with a TC of 16,700 and a CRP of 63. And creatinine is also 49, 1.3. So, ma'am, the diagnosis, because this is a very typical respiratory patient.
Thank you, Dr. Arindam. This is a very common patient in any ICU. This is acute exacerbation of COPD with a background of ischemic heart disease, and the patient has a hypercapnic respiratory failure. The patient is on NIV, and his BMI is less. Maybe he has more of an emphysema component, and he has his infection is also high. So this is a case who has already been a COPD emphysematous type for quite some time, because maybe he had high work of breathing and his nutritional status was not good. And that happens in many of the COPD patients, and they suffer from some sarcopenia because of less nutrition. With the work of breathing, they cannot eat well. So this patient has been put on NIV, and this is very challenging from the nutritional aspect, because this patient has to be given good nutrition, because unless he has got good nutrition, his overall respiratory status will not improve. But with the NIV, it is really very difficult to start on nutrition. So what to do, eat or breathe? So that is the question which is most challenging. And we should start early on nutrition.
Now, I would move with that question to Dr. Kole.
Okay.
So, as ma'am has told already, that to eat or breathe, but we can't stop either. Okay, so, and there is always a problem with NIV, that it is an inherent sensation of bloating, and also there is aerobagging. Okay, so
actually NIV, that is in the system, we are trying to cause negative pressure.
Ultimately, it expansion of the respiratory muscles and increases the pleural pressure and alveolar pressure also. So, if the patient is on needs like intermittent NIV and his GI tolerance is good, then we can go through the interfeed. But if the patient is, say, if the patient is continuously need the NIV and also sometimes she is quite unconscious, and in those cases, if we give Ryan's tube through the Ryan's tube continuously, and there is a chance of air leakage, so it is very difficult to do in case of the non-invasive ventilation.
So how do you select cases? So which patient do we need to put an NG tube and not in? Because in some ICUs there is a routine practice that this patient is on NIV, so they just put an NG tube preemptively.
I think that is not correct. That is not correct. We have to think of the assess nutritional requirement, at the same time also the respiratory requirement also. Accordingly, we have to go for that. And in that case, if the patient is continuously needed the NIV, I think better choice should be the parenteral nutrition.
So, sir, what are the criteria when we should consider parenteral nutrition on a patient on NIV?
That I told you, that when the patient needs a continuous, patient is stupor, patient is unconscious, and in that case, we should think of the parenteral nutrition.
Okay, sir. So, are you suggesting to go for a parenteral nutrition along with trophic feed? I guess parenteral nutrition with trophic feed. Okay, sir. But Guru, what is your take on this? Cause guidelines slightly differ on this.
I think jejunal feeding will be could be tried in this patient.
Jejunal feeding.
Jejunal feeding.
Okay. So let's see, cause whatever we are missing in this discussion are the nutritional issues in the COPD. Okay, so first, unless and until we know what are the nutritional issues in the COPD case, and what are the things that we need to look into, what are the things we need to incorporate into the assessment. So, apart from this case, this is a case with a low BMI, but sometimes we see many patients who are usually overweight, usually the chronic bronchitis phenotypes. They are usually overweight, they usually have an associated OSA component, and if not, then associated DM or other AKI or CKD components as well. So those things comes and often interact. And also the impact of weight and mortality and morbidity, cause there has been good evidences that with loss of weight there is increase in mortality. And also with low BMI there has been evidence of increased and prolonged hospital stay, prolonged on ventilation days and double intubation. So I will skip for now. This is the malnutrition definition, and this is the WHO definition. So how do you think that we need to look at the weight management in the ICU? Do we need to look at the weight management in a critically ill patient, or we can postpone that to the post-hospital, post-discharge days? We can manage with the minimal nutrition that is required, or the
Actually, nutrition should start early, as already been discussed in the previous sessions. But especially if we go by this patient who is already nutritionally poor with BMI of 16, I think we should put enough importance to his nutritional status rather than waiting for the discharge. And this should start from the beginning. And regarding the usage of non-invasive ventilation, there is always a chance of aspiration when you are using non-invasive ventilation, especially if it is very high, high level of pressures are used. But we might, maybe after 6 hours we find that the patient's gases have come down. We can wait and see how the patient's sensorium is good, then we can obviously try. And the other thing is, there are many, and there have been many trials regarding many studies also regarding issues of enteral and parenteral nutrition and early usage of nutrition in patients having non-invasive ventilation. And the approach should be a bit individualistic depending on the patient.
Ma'am, sorry to interrupt, but I think this question of altered consciousness doesn't apply to this case of
patient doesn't apply.
not only this patient was on NIV. NIV is itself a contraindication to patient with altered
Yes, but
sense organ.
sometimes what happens, some patients are, we also put little bit drowsy patients are also put on NIV and the patient's sensorial improves by giving NIV. It is contraindicated in absolutely drowsy or absolutely unconscious patients, but sometimes little bit
Yeah, a little
drowsy
sort of
patients,
trial,
yes.
or sort of 4 hours, 6 hour trial like
Yes,
that.
so we can see if the patient is better. We can try some, and some patients, if it is not very dyspneic, the respiration rate is not very high, we can even try some oral fix, or we can try the enteral with the Rice tube. Maybe there is a difference, but there are some kinds of masks, like the helmet mask and all, which can minimize leakage, and also we can also try some other kinds of masks like nasal mask, if it is possible, by which you can give better oral nutrition, and also in some patients other kinds of adaptations are employed in the nasogastric tube, and of course what Dr. Guru Prasad said about the jejunal feed that gives less aspiration.
Okay, ma'am. So with this we move on to the next slide. I think this has already been discussed by Sulabhkina ma'am, because this is pertinent to any critically ill patient. This hypercatabolic states, and these are the data supporting 1 year mortality according to BMI. So we can skip this slide. So symptom burden and quality of life, which is very much important, because with nowadays GOLD also recommending that rehabilitation should start from the very point of contact with the healthcare, and that impacts the quality of life and also symptom burden. And with that, pulmonary rehab, nutritional rehab is also a part of it. So, madam, what is your take on nutritional assessment of patients in ICU?
Nutritional assessment you have to do because it is always done. You have to see the patient clinically and assess his status of nutrition. It's not always that always you measure all those circumferences and all, but overall look at the nutritional status, albumin and all can give a clue. And but the thing is, regarding physical rehabilitation, it should go hand in hand. And also for a patient with NIV, because our patient is on NIV, so I will not talk about patients who are domiciliary on domiciliary treatment.
Yeah, we will keep it confined to the critically ill patients only.
We will only discuss about this particular patient on NIV, which is really very challenging, because not only from the question of aspiration, but intermittent removal of the mask can also lead to increase of carbon dioxide. This has to be judged, and maybe if the patient is clinically improving, just by going through the gases, it is not always advisable that the patient is having a 55 or 60 PCOD that will make a lot of a change in his overall status. But if his rates are low, I mean the respiration rates are low and the patient is otherwise fit, then we should continue with the enteral, or even if possible with the oral nutrition, along with physiotherapy of course. And another thing, we should always also have a look whether if it is an enteral feed, like some studies have been done, like gastric reserve volume. If it is less than 500, then it is advisable. If it is more than 500, then we may have to skip and wait and see, and then again rethink about giving the enteral feed.
So I move on to Dr. Kole sir. Sir, slide apart. So as far as the nutritional estimation is concerned, so as we have seen in the previous slides that there is almost 4 times increased work of breathing. The calorie consumption for breathing from normal 100 kilocalorie comes to almost 400 to 700 around. Okay, so that increases the resting energy expenditure RE, which in turn decreases the fat-free mass in the patient. So, sir, do we need any target for any weight gain or something? So, do we have from the very beginning we need to start that? Okay, this patient is having this much BMI, so we need to target this BMI over this period or this sort of weight gain to assess this adequate nutrition.
And definitely opt for the this patient was definitely malnutrition. We have to make it in a normal nutrition within say around 20, 21, 24 like that. And in case of COPD, probably we should make it in a higher side. And apart from these clinical aspects, we can measure the other issues also. We are creatinine, albumin, etc. But with that we can assess all the issues.
Sir, actually, I am asking that there is precise studies and recommendations that around 2 kg weight loss is 2 kg weight gain is expected for the next 4 weeks. Okay, so that increases the survival in hospitalizations. But sir, my question is that there has been that resting energy expenditure along with that. So should we go more for the protein or the carbohydrate or the fat? Because there has been old school and traditional teaching that more the carbohydrate we give, there is a more increase in the PCO2.
In fact, in my opinion, the emphasis should be on protein because there is more protein breakdown, more need of the protein in the physically weak patients. And in my experience, I will emphasize on the point that the physically weak patients should at least not lose weight. We should try to maintain the weight by adding extra calories, because calories, as the previous speaker was saying, calories cannot be made with the kitchen homogeneous foods. It has to be supplemented by some formula foods. Calories.
So that is what I am trying to say, that calories are in a normal nutritional session, the calories is around 30 kilocalorie per kg body weight. But we have to increase that to almost 40-45 kilocalorie per kg of body weight. So if we need to target that body weight increase. And also we should emphasize on the protein deficiency as well. So normally the recommended protein intake is around 1 gram per kg body weight, which needs to be increased up to even 1.5 gram per kg body weight.
1.5.
So these are the very simple questions, 7 simple questions that forms the basis of the nutritional rehabilitations. So I won't go to the details of everyone. So this is the high risk of malnutrition, and this is why we need to give nutrition. But my question is, what are the factors that we often neglect or often that gets overlooked in an ICU? Because in the ICU, when we are busy with Apache scoring, a SOFA scoring, okay, and also the antibiotic, bioexam, and all these things, we often miss some of these. So, can you add, sir, madam, anything to this that?
Regular clinical monitoring is very much essential by not only the doctor but also the nursing staff, nutritional, the dietitians should come. That what Dr. Srinivasan was telling.
Absolutely, it's a multimodal task force.
Come and visit and assess nutrition because they have got some more parameters of assessment, and accordingly they should tailor the nutritional the supplements, whatever, not only like minerals, protein intake should be increased, but not only that, they should have some more vitamins and trace elements. Vitamin D is also very much important for patients of COPD. So these things have to be taken care of.
So this is the last latest guidance we spent 2019. This is 2014, but there have been 19 as well. We take 2014 screenshot version. So what is your take on oral nutritional supplements in malnourished COPD patients? Because as far as the nutritional deficiencies are concerned, they are almost similar, be it a COPD or be it ILD or asthma. So, do you recommend oral nutritional supplements on a routine basis to the critically ill COPD patients or respiratory patients?
We should use it. And
Especially, sir, when we consider that COPD is a multi-system disorder with a very high oxidant stress, and Gold is also recommending that vitamin C decreases the COPD symptom burden and also overall health status of the patient. And also there are concomitant other micronutrient deficiencies like the vitamin D, which also shows limited number of exacerbations in case of patients who receive the vitamin D supplements. So A, C, E and D, these supplements should be kept in mind. So this has already been done. So this is the SGS code. This has been, I think, beyond the scope of this discussion as of now. So this is also that we first go for oral supplements or the oral route, enteral route, then only go for the parenteral. Madam has already dealt with similar slide. This is a guide, sorry for the picture quality, this is a guideline for the respiratory healthcare professional, particularly for COPD. And this is a brief monitor. I think that there should be not be any elaboration on this because these are more or less standards and followed everywhere. Thank you.
So, to conclude, for patients of COPD coming to ICU, nutrition is extremely important, be it having less body BMI or higher BMI. So we must take care of the nutrition. Even if the patient is on a non-invasive ventilation, we should start nutrition as soon as possible, and because that reduces the mortality. And also in ventilated patients, we should, that has already been discussed, we should also take care of the nutrition, especially giving emphasis on protein and other vitamins and trace elements, along with physical rehab, physiotherapies and all. So nutrition is an important aspect which we should not neglect for our patients.
Thank you, ma'am. Thank you, Mr.
And most importantly, the nutrition is a team effort, and where the doctors, sisters, and the dietitians, physiotherapists, they play a major role. But most of the hospitals, we don't have any guideline regarding that. And ideally, there should be a committee with all of them, and we should assess the patient regularly, and according to the necessity we can.
That's the problem that we all must emphasize, that whenever a patient is admitted, that the dietitian comes and goes with the advice that this patient needs a renal diet, this patient needs a salt restricted diet, and that's it, without even proper mentioning of how much calorie does the patient need and in what proportion of what. So it is a team effort, it is a multimodal thing, and that needs to be attended like that. So when the concept of stewardship in case of antibiotics and antimicrobial stewardship, it was also not well organized. And so this is a very new journey of nutritional stewardship, and we think that in near future we will see those team efforts as we see in antimicrobial diseases nowadays. Thank you.